So could I have the other speakers up here? I would like to thank the speakers. Not only did they do an extraordinarily good job of presenting, but they stayed pretty close to on time. And so we really have actually, I believe, about a half hour of questions and answers for them. And we'll get them all sitting up here. And as I said before, what your great opportunity here is to ask questions. Yeah, Jack, you can sit there. Is your opportunities to ask questions. Peter had one a little bit ago, so I know he's got one sitting out there. But I would like you to come and question all the speakers. So we'll start with Elon, who's up there first. Okay.
Yeah, thank you. Fantastic talks all around. I'm interested in opinions, particularly from the cryptococcologists here, about including Dr. Perfect, about the applicability of the ambition protocol to patients in North America. So I know this is an issue that a lot of us grapple with and probably not something that we're going to be able to resolve in a few minutes, but I think that this might be a venue for some robust discussion. Thank you in advance.
So I think we'll start with Tom on that one. He's thought about that a little bit, and we'll have him.
Yeah, John says we have half an hour, but we do want to discuss other things. It is difficult, and I think it's pretty hard to summarize. And just to flag up that because we've been asked that question so many times, we have put together a response to it. And essentially, I think we do believe that there should be a two-way process. Doctors in low and middle-income countries have been looking at evidence from high-income countries for decades and adapting it to their setting. And there are no recent trials in cryptococcal treatment in high-income country settings. And yet there's a lot of work being gone on in Africa. And some of it has some relevance. So that's just a general point. But if you go through it point by point, is this regimen a compromise regimen for poor countries? Not actually. It's a triple regimen. The rates of clearance match from, and I mean, there is no direct comparison. Sorry, that's another caveat to put right up. But, you know, if you look at all the data, there's no reason to expect that the rate of clearance with the ambisome triple regimen is going to be inferior. It's going to be at least as good. It's certainly a safe regimen. And I mean, you know, there are, and a cost-effective one. So I personally, it's not my style to try to, I don't feel comfortable telling people what to do, but I think it's an option that should be discussed. Read our side of it, and then you can read the responses.
Yeah, I think Tom's right. I'd say the same thing. We need to talk more about it. I'll talk a little bit about it later this afternoon. It's a complex issue, and I think it will sort itself out as more and more experience comes with it. So I think you get a good statement to that. I think we need to talk about it. We need to continue to try to understand it, and we need to continue to try to study it. Twee.
I have two questions for the Cryptococcus experts. So the first one is David. The mortality is very low, 15%, even though the number is small. But what is the inclusion criteria for your earlier trial for the oral M4B? And what kind of patient did you exclude?
Yeah, so primarily GCS 15, so you have to have Glasgow Coma Scale of 15 and be able to have capacity to consent and be able to swallow oral medicines and be CSF cryptococcal antigen positive. And so there's some other inclusion-exclusion criteria, but the only large group that's being excluded is those with altered mental status. In part because then you could use NG tubes, but then you need stability data and how does XYZ compounds interact with NG tubes, and so it gets a little bit more complicated from a drug trial perspective. So I think one of the other things that in the background is the cryptococcal antigen screening programs that David May and Radha have been involved with, that by rolling out Craig's screening, we are picking up people earlier in the sort of disease process, and so they just have less severe disease, slightly lower fungal burdens than what we saw 5 years ago. And the outcomes of those patients who are Craig screened are are better as far as survival to hospital discharge, by about 50% better than those who just present with meningitis symptoms. And so that is in the background of things happening in Uganda, where about half the people are being referred to hospital, being picked up early and due to Craig screening programs with symptomatic meningitis, but picked up early. So that's probably why some of the mortality is better, but it's a randomized trial, and so those people are equal in both groups. And when you look at demographics, they're equal.
Are you including people with Glasgow Coma scale less than 14, 15 in your current stages?
So no, just 15 and just normal mental status with the ability to take oral medicine. And currently that's about 90% of our crypto patients. So we're excluding about 10% of patients who present. So it's not a super large proportion.
The second question is for both of you, Tom and David. In crypto trial, you pick 10 weeks as your primary outcome. Where does that time come from? And I know that it started with your phase 2 work, Tom, and other things, but I'm very concerned about the HIV population specifically because it's a very, very tenuous time when these patients, most of them are not on antiretroviral therapy or recently started on therapy. And when you have the bug and the host immune systems interacting, and particularly with the drugs that are not very potent, we do see late mortality and in multiple survival curve that you show in earlier cohorts as well as in the ACTA trial. There was still excess mortality after week 10. So I'm just concerned that week 10 is not really fully capture the mortality, excess mortality, particularly in HIV patients. And just wondering what your thought about that primary endpoint.
Well, I think originally, for me, it came from the Van der Horst study, where they had a cutoff at 10 weeks. So I think, and of course, yes, it was somewhat arbitrary. But certainly in our data, it is an inflection point. I mean, it's not a perfect inflection point, but the curves do flatten out. And but because of this issue, that's why, for example, in ACTA, we had that substantial, it's about a third or more of the patients in Malawi we followed to 12 months to make sure that there was no change in the trial results, essentially. And as you saw, there really was a flattening out, particularly in that 1 week and flucytosine regimen. Surely we know with fluconazole monotherapy, mortality just continues. And I mean, there is no flattening of the curve. So your point is well taken. Yeah.
Yeah, I think 18 weeks is the sweet spot where our mortality curves flatten out. But 10 weeks is the historical precedent, and that's what FDA uses. And so that's what everyone is going to use moving forward. Whether or not it's the right endpoint, it's probably definitely not, but that's what we're going to use.
David, could you just comment again when you were talking about, Twee asked about the low mortality, just to give the audience a little bit of impact of what you think the influence of opening pressure is and lumbar punctures and stuff like that, just to kind of comment on that, because we talk about the drugs, but there's other things that...
Yeah, I mean, the mortality, I mean, I can give a 30-minute talk about sort of all the supportive care aspects that we've gone through of IV fluids and potassium and scheduled lumbar punctures, and so we just published in CID, the survival impact of LPs, and so there's stigma against LPs. The IRBs don't like LPs. They think they're dangerous. And so we've always had a protocol where this is our recommended schedule of LPs, but people can opt out of those if they wish, even though it's not recommended. And so some people will opt out of those. And so when we go back and look at the data, the more LPs you have in the first week, among the people who survive 1 week, after that, there's a survival benefit. And so if you get one LP in the first week, there's a survival benefit. And the more LPs you get in the first week, there's a survival benefit after 1 week. And so LPs are a critical component. And so that's a little problematic in Africa where you don't have access manometers. Things like lidocaine aren't always present. And so that's a critical aspect of cryptococcal care.
Okay, thanks. So Peter, you were up here a little bit ago, and you're back again, so it's yours.
All right. So I want to echo your comment on non-HIV crypto or the crypto in the U.S. that it's a good advertisement because we have a 25 center cohort of solid organ transplants, non-HIV that we're putting together. But you're absolutely right. Nothing's been done in the developing countries since like the 70s. And it really needs to be done. So that was good advertisement for Donna. But the question I actually had was to Olivia about biomarkers and things. Respiratory is very difficult, but neuro is particularly difficult. We have patients that come in comas and go back to work, wake up and go back to work. And we haven't found a single neurologic clinical marker that you can go from coma to normal functioning. Isn't that amazing? With all the stroke research and everything like that. And there's like 3 different kind of groups you have to go through in order to be that. It's not even a clinical marker. And as far as radiology, there's like nothing. Some work and consensus really needs to be done on that. Because we have not even the beginnings of neurologic diseases, and Cryptococcus is certainly the prominent one. Yeah. Have you run across anything neurologically on that could benefit? Because like Mocha looks high up, Karnofsky's better lower. Stroke index,
No.
Okay.
Point out, if you're interested in that, talk to Masa Abbasi, who's here. Wave your hand, Masa. So that's like the focus of our K23 is looking at sort of some of the metabolomics and proteomics and CSF and how that correlates in people with altered mental status and what you can do to basically improve the survival in that population.
Yeah. All right, thanks.
Yeah. So Peter, you emphasized a good point. We talk about survival, but how did we survive? And what's the outcome of these patients that have cryptococcal meningitis and outcomes or morbidities and stuff like that? This still needs
Cryptococcus and non-HIV, nobody should die. And our expectations are getting higher and higher. You used to get, if you lived, you got parked in front of a TV for the rest of your life. You just kind of sat there. And now our expectation is, can you get back to work? Can you, go back to normal functioning? And so it really is good to have those markers because our expectations are just getting higher and higher. Thanks.
Hi,
Yes.
I'm Radha Rajasingham from the University of Minnesota. My question is for Jack. You discussed some interesting new antifungals for vulvovaginal candidiasis. I was a little disheartened to hear that women of childbearing age are not included in those studies. I'm wondering if there's any plans to include those women, given that that is such a huge component of your population of interest.
Sorry, the which population?
The women of childbearing age.
not
As you know, the frequency, the incidence of vulvovaginal candidiasis drops dramatically postmenopausally. So that in fact, this is predominantly this is a problem of premenopausal women. So the implications are that with regard to a target population for this new drug, for isoconazole, there's a 70% at least reduction in potential women who are qualified on the basis of not being adequately controlled by fluconazole, and who, after years and years of being on fluconazole, and I mean years, up to 10, 15 years of remaining on fluconazole would be ideal, or are precluded from going on to isoconazole. So that's a major limitation.
Yeah, Jack, so I just emphasize that again. I think what she's asking is one of the concerning things that I see in that is impressive as these new drugs are, their half-lives are so long.
Yes.
That the issue around childbearing age people taking this becomes very tricky. And I don't know if the companies have, they just said, no, don't do it. But do we really know what that risk is? That really limits.
Well, so the real issue here is if you look at the limitations demanded by the FDA, you're talking about postmenopausal women, one. You're talking about women who cannot become pregnant. They've had a tubal ligation, they've had hysterectomy, but in essence, you are talking about women, that cannot become pregnant. We do not know the long-term consequences of the sustained tissue concentrations.
So it seems like we need most of a host-driven clinical trial, right? Like more focus on the host that really has this disease rather on people that can take the drug, right?
In terms of the host, I'm not quite sure.
Because you are sparing all the women that are at higher risk of having vaginal candidiasis, actually.
Yeah. So you continue to have, even women in their 40s, 50s, and 60s are still going to get recurrent candida vaginal candidiasis. The predisposing factors, the genetic factors persist. And once a woman goes on to hormone replacement therapy, estrogen replacement therapy, she remains at risk. So there's still a sizable portion of women who have no reproductive capacity who remain at risk and are vulnerable. Mm-hmm. The other issue is whether or not studies will be done to confirm safety in younger women. In other words, to go back to the original embryo toxicity studies that were done in animals and to see whether, in fact, they are relevant and whether or not. But that's a long-term challenge to challenging the authority of the FDA, in essence.
Mm-hmm.
Sorry.
Thomas.
Yes. My congratulations to all of the members for outstanding presentations. Oliver, question, if I may. In serving on DRCs, we've seen approximately 50% of patients that may have pre-existing serum galactomannan. It may vary. But when we're adjudicating cases, if we consider the clinical manifestations are ambiguous, as you've nicely stated, that we may have no biomarkers, or if we do have a biomarker, it's not really taken into account. And the driving factor for determining therapeutic response often hinges on the radiology. Unfortunately, that is often the most ambiguous, because you may have multiple lesions, some respond, some may not. You may have some members of the committee that will say, yes, there's a response, and we get down to that ambiguous 50%, less than 50%, greater than 50%. And the potential reproducibility of that leaves something to be greatly desired. To refine it farther, for those patients that have a positive serum galactomannan, why do we not, or perhaps we should, incorporate, for that population at least, the documentation that resolution of galactomannan antigenemia can be counted as a microbiological clearance. I know we've discussed this in a number of DRCs, but it never seems to take traction. Yet it would give much more refinement to the often anguish that goes over the radiology, which may lag far behind.
Yeah, that's a good point. Thank you. Actually, so one step further, if no CT scan is done in that patient at that time, then it's a success. But if there is a CT scan done, then it's a failure. So that doesn't make sense, and we need to refine on these criteria. And even a new lesion. I mean, if there is a new lesion, then it's a failure. But that's not true, because the new lesion might be a sign of success because neutrophils coming back and there is a new lesion and it's not massive. So why isn't that still should be counted as a success? It is pretty difficult, and the radiology has too much weight in that decision process for quite some populations. And another example, we didn't bring it up, but another example would be a clinical trial on pneumocystis. And you know that you stop the drugs while the imaging is still terrible, but you can stop the drugs and you make that clinical decision. Otherwise, you can go on forever with treating. So that would be another example where too much weight on too much meaning on the radiological part.
What do you see as the future for biomarkers in that more global assessment? We could even include pneumocystis in there, but certainly for aspergillosis.
Well, I envision lots of discussions.
Very good.
And it would be good to have all the DRCs follow the same rules. That would be great.
Okay.
And then we could even run analyses across clinical trials.
Thank you.
Thank you.
Karen?
Just to expand on this great question a little bit more, we did those analysis in the combination therapy study that was supported by Pfizer, the Antigen Vori study. And it showed two things. One is that the people who had decrease in galactomannan actually did better. They survived more. The second one is that if you align them according to low and high galactomannans, the only difference that could be witnessed were the people that came in the middle. It's like that Goldilocks effect. And these data have been virtually ignored in interpreting this study by many people who are, I think, overestimating and not understanding what happened with the overall mortality in that trial. And just to go a step further and very relevant to the conversations that on trial design, we had an improvement of overall survival when those data were initially evaluated by the DSMB, and they recommended an increase in enrollment in order to be more certain that there would be a better survival in the combination study. This is something that has not been well publicized. And then what happened was that one of our very, very productive and great investigators enrolled a bunch of people with relapsed AML, and you can probably guess where that came from. The overall death rate was then skewed on those later enrollments, and the trend actually went to non-significant, but just the trend. And this is so reminiscent of the biggest lesson that Jack brings out today, which is really be careful with what you're trying to measure, because that antifungal therapy is not going to really, you're not going to see a difference in someone who's got that severe of AML relapse. So these questions are really very important, and I think that more conversation it would be very, very worthy. Thank you for your presentation.
Thank you. And sometimes trial design can really harm, because that was the end of the story for combination treatment for aspergillosis, and still we don't know. But you're convinced and that it's beneficial, I believe, and but we still don't have the solid evidence, so to say, that combination is efficient. And maybe it's good to just go in like what Ambition just told us, hit hard and early.
Heron Schlamm and I have talked for a number of years about actually writing down this story and showing what actually happened under the sheets there. And I think it may be actually pretty valuable.
John.
John Badley, University of Maryland. So a couple of words to think about: duration of therapy. Those of you who take care of patients in the hospital realize that, the dogma was 14 days of antibacterials for everything, and it's all changed. Now we use 7 days and people do fine, most people, right? So can we do better with antifungal therapies, endemic mycoses, maybe simpler candidemias, and how do we address appropriate duration in some of our clinical trials?
Shall I start?
Go for it.
Okay, candidemia, we could easily do a randomized clinical trial, 14 versus 10, let's say. I wouldn't go for 5, but 14 versus 10 could be done. And you would likely only randomize patients very late, before day 10, so that you know whether they have a complicated candidemia and if it were just defined by the duration of positive blood culture days. It could be done.
I think obviously this is where the role of figuring out the PK of the drug, and so some drugs may have super long half-lives, so amphotericin in tissue, for instance, has a really long half-life, and so working out some of that in animal models before you're going into trials so you can design your trials appropriately.
In that randomized scenario that I had in mind, it would be, of course, the same treatment in both arms. So for candidemia, it would be echinocandin and likely not rezafungin, because then you are that study has already been done, so to say.
So John, I think you asked a really important question in all of infectious disease, is how long do we really need to treat? And the fungal stuff is right in the middle of that. So I think designs of trying to understand how long we need to be done.
And that is an MSG question, actually, because that is not a question to go after for a pharmaceutical company, right?
That's correct. It's an MSG type question. Don.
Hi, Don Silla, Pillai Therapeutics. Thank you very much for all the great presentations today. As a drug developer, I've always been very interested in areas where clinical practice meets clinical trials. And a number of you had comments on things in there like missing data or other things like that. One of the really interesting issues I thought was salvage therapy, where Dr. Miceli, I think you said in salvage therapy, if you have a person who hasn't failed yet, but you know they'll do better on the next therapy, why not just convert them now? As a drug developer, I look at something like it and say that now you've missed an endpoint in that particular trial or that particular person, you might have harmed the overall ability of the trial to detect differences in a therapy that may work in the future. So I wonder, as you look at these things, are there things that we're doing wrong in the way we develop standards and our trials, or are there other things that we need to think about when it comes to clinical practice standards meeting clinical studies?
I mean, personally, I think that the questions we had is based on what we see every day with the patients. And I think the pharmaceuticals are doing a great job offering these new drugs and investing on those. But I think we are too polarized, so we think a lot about our patients and what we see every day, and probably pharma is focused on the product. So we really need to intersect. And unfortunately, when we deal with patients with infections that we know that we don't have good options for treatment, like lamentaspora, patients with fusarium, or things like that, that we know that they're going to fail whatever we are giving them, particularly when we have sensitivity information. So we really want to put those patients on a drug that is going to, we know that there's more hope, right? So, and many times we are just kind of, we know the patient will be eligible, we know that the patient may have a chance with that, and we cannot enroll that patient until the patient didn't do well for a given number of days, which is also very arbitrary, right? So that's what I was talking about, like probably talking about from frustration, right, from treating those patients. So I think that aspect needs to be taken into account when designing such a trial. That, probably also, patients, we understand that we need to kind of enroll patients that are going to have some sort of survival from their underlying condition, but we want to give the chance for those patients that may survive more, like longer, because their underlying condition is, is doing better, but they would die with this unfortunate fungal infection.
Ilan.
Yeah, so, we're fortunate to have two of the panelists on stage have been at the forefront of trials in COVID, which has really kind of turned on its head how we run clinical trials. And so I'm interested for Oliver and David, what lessons can we take away from the pandemic and how we can transform clinical trials for mycology going forward?
You go first.
Okay, so so I think some of you know that, my team, which is not just me, but my team, we ran a couple trials early in the pandemic with hydroxychloroquine, and I've been involved with some ivermectin and metformin and fluvoxamine trials since then. And so, our hydroxychloroquine trial cost less than $100,000 to run a nationwide, multi-site, clinical trial that was very pragmatically driven, based on, simple endpoints, sort of patient-reported outcomes. It wasn't fancy, but it was quick, and it was, very easy to do. But it was for an already existing, drug, and so not really appropriate for a registrational trial, but for a strategy trial, something like that could work. And so I think that from the MSG perspective, for sort of strategy questions on duration of therapy, or is drug X or drug Y better, these sort of decentralized trials using the internet, would be certainly a way of the future, because it's not going to be a traditional clinical trial model. Those trials are too expensive and too slow. And so if you're interested in this concept and want to talk about it, Matt Pullen, who's somewhere in the room, has a poster about, in the back, he has a poster about kind of a concept that we'd sort of like to float for endemic mycoses. As you know, there's been nothing in endemic mycoses really in clinical research for, well, a long time, since about the time I graduated from medical school. So trying to use sort of an internet-based approach of can we get sort of at least sort of initial sort of like a registry basically as a starting point, and then if that's successful, then you can sort of move into the realm of randomized trials for strategy and things like that. So do talk to Matt Poland. His poster's somewhere over there, and he'll be here. And there's a number of people involved in this sort of interest, and so their names are also on the poster.
Another smaller aspect is what is important. Don't stop your clinical trials just because there is a pandemic. So that doesn't make sense. It would have meant, we didn't stop any of the fungal trials because it would have meant withholding salvage treatment from patients, which is, and you just can't do that without a pandemic. And then with the European perspective, it comes down to all the authorities, and in Germany alone we have about 60 ethics committees. So if you would go for a clinical trial that's really a pragmatic trial, so in many sites, that's what you have to accommodate 60 ethics committees just in Germany. So that would call, and it was easier during Corona because you could go through just one ethics committee and everybody else had to accept. And that was just by the change of 3 words in the respective law.
Because of time, I'm going to take 2 more that have been standing up over here. Demetrius?
Yeah, I would like just to point out 2 real-life problems in assessment based on CTs that maybe you have touched or not. Maybe comes from the SKU experience since people with relapse leukemia late in the stage of the disease. We have an abstract in ID week when we look in people who grew mucor, and the same applies for aspergillus in BAL, and 1/3 of those has a gram-negative in the BAL, typically multi-drug resistant, like Stenotrophomonas maltophilia. That brings the question, when you look at CT in the follow-up, nobody assesses the adequacy of antibacterial therapy and what that means. Second, all the new, and I'm going to talk about it later on, new adeneoplastic therapies have some pulmonary toxicity, like checkpoint inhibitor pneumonitis. How you account that in the follow-up CT? Third, there is a famous paper in my institution by Erasmus et al. When different radiologists look in lung cancer progression in phase 1, phase 2 trials, and the discordance rate between radiologists was 33%. So what is the difficulty on that? And for all this excellent discussion, there is an amazing editorial that I invite all of us to read, which is by Rich Wenzel, called The Fragile Anatomy of Crude Mortality, that talks about how crude mortality can be so problematic, especially for opportunistic infections. And I think maybe for Cryptococcus applies to some degree, but that's another problem in clinical study design.
One more question, and then maybe we'll have one more. Go ahead.
Okay. Thanks. Great presentations. Marissa and Sharon, this is about your presentation. I think you gave a great presentation describing all the potential patient types that can be studied in clinical trials, but many of them are relatively small populations, patients with hard-to-treat fungal infections, pediatrics, endocarditis, et cetera. So let's say one of the drug developers generates pretty good data with their drug in those patients and wants to go to the agency and have a discussion about potential labeling. The agency is going to say, okay, where's the comparative data? And how are you comparing the outcomes in your patients with the outcomes in patients who get standard treatment or something like that? And this is something that I think all the companies are struggling with, particularly when they get to the agency. There was even one situation where I think for Cresemba, the Astellas went to the agency with a comparative group from a registry, and the agency rejected it because there wasn't a pre-specified non-inferiority margin agreed upon to finalize that comparison. So it just gives you an idea of the kinds of struggles that we're going through. So what I'm getting to is there any interest in the MSGERG to put together these comparative data to help us with registries, help us with other resources, literature searches, to put together solid comparative data in patients who are getting standard of care for these infections that we can take to the agency and use for these purposes.
I mean, I think that's an excellent idea, and I think this is where we need to work together to kind of set the ground, right? So for something like that, yeah. Thanks.
Yeah, I would say this is what MSG could be good at, actually. One more, and I know I'm going over time.
Kariba Donovan from University of Arizona. I just have a comment about the fluconazole use in pregnancy. Dealing with coccidiomycosis meningitis, we have to use fluconazole when patients are pregnant. So what we usually do, first trimester is amphotericin, and then we can switch them to fluconazole as it is indicated. So we don't exclude fluconazole during the whole pregnancy. That was just a comment.
So the fluconazole having been introduced in the 1990s as the first oral therapy, well, following ketoconazole, but which was no longer used, there were several studies done looking at pregnant women. In between 1990 and 2014, 2015, at least half a dozen publications, no evidence that at the doses used for vaginal candidiasis, not cryptococcal meningitis, there was any problems with the fetus. And then they did studies where they increased the volume, the numbers of patients enrolled, they just changed the methodology, and 3 major publications appeared after 2015 showing that a single dose of fluconazole administered any time in the first 2 trimesters was associated with fetal loss and other congenital abnormalities. So the fact that we often have studies that fail to show and to recognize problems doesn't mean this is the last word. There's very good evidence that fluconazole should never be given in pregnancy.
Okay, so first of all, thank all the speakers here. I think they did an outstanding job. I thank you, the audience, which I've asked multiple times for questions, and you've done a lot of questions, so much so that I've gone over time. But I think it's worth hearing these things because I think they're important issues. What we have now is a break. It's supposed to be 15 minutes. I'll say let's make it maybe 10 minutes. Try to be back here at roughly 10:30 to say and go over the antibiotic 2 type of studies. So thank you all for your questions, and thank the speakers for excellent presentation.